I'll be right here.
Hello? I don't think it's on. I don't think it's on though. The mic.
And we need to get ready to start swinging louder.
Only when I'm at home yelling at kids.
Oh, I was just gonna say.
Then look out.
My nephews, I'm like yelling at them, like, what is going on? Okay, why do you?
Yeah, I noticed that it's working. It's just like the speakers.
Oh, the speakers are down? Oh, maybe it's one of these?
So this is the gooseneck. This is for Panopto. And this is normally the speakers within the classroom. And I tried turning on, turning off, and
Yeah, I don't hear anything.
I was talking to Rupo, and she's like, could you let people yell?
Yes.
It's like,
They really
and
do.
I was playing around with it.
Oh, sorry.
No, it's fine. Like, it's on. That's the thing.
so like
Yeah.
on Panopto, whatever I said this morning
It was
should
recorded,
hopefully.
yeah.
It's recording,
just
yeah.
because-
Okay,
yeah,
so
so-
for the live people, we'll have to.
Exactly. I mean, it was fine. We
Yeah.
were able to hear
Okay.
you.
Yeah.
But just is working.
Yeah, okay, all right.
And I'll double check with the recording now just to see if it worked. But I'm not sure what's going on with the microphone. I'll send an email to
I
the
don't hear
IT.
the speakers, thanks.
Yeah. So let me just restart the.
Somebody messed around with this down here. Okay, cool, thanks. All right, guys, do you want to start?
Let's rock and roll.
Let's rock this. So lipids are probably the easiest drug class to study, right? So the only thing you have to know is give a statin. All right, see you guys later.
Yes.
No, that's basically it. I mean, we joke around about it, but that's essentially, and you'll see why that's the case. So here's the learning objectives, all listed there for your review. I used to teach this concept, or this course with pathophysiology. Was the same course. So the first half of this presentation is a lot of pathophys review. I'll kind of just go over some things. It's here for your studying and for your individual reviewing, but we're not going to spend a lot of time on this. We're going to go right to the drugs. Okay. And then I know Dr. Shah wanted to talk a little bit about management of some of these patients on these drugs. The hyperlipidemia lecture, the diuretics lecture, and probably the antiarrhythmics lecture are probably the three that are honed into specific drug classes. All right, so all those drugs have a common, very similar mechanism of action. The other lectures, the coronary artery disease, acute coronary syndromes, hypertension, those are kind of in gray zones because they actually use 4, 5, maybe 6 different drug classes to treat that disease or that syndrome. And so the way these pharmacology lectures are going to play out is that, there's going to be a handful of individual lectures such as this one, but starting tomorrow with hypertension and Friday with diuretics, there's going to be multiple drug classes that we're going to go over. Okay, and we're going to highlight the specific drug class in regards to the disease that we're talking about on that day. So towards the end of the unit, the cardiovascular unit, you can put all the drugs together and then, kind of have a clear understanding of how these are supposed to work. Because we'll use beta blockers in many of these diseases or syndromes. We'll use calcium channel blockers again and again. We'll talk about nitrates and how important they are. And so you'll see these drugs keep coming up. Okay, so we'll kind of start, just as Dr. Shah said, we're going to look at the vessels and the problem of having too much cholesterol in the vessel and what that means for the beginnings of hypertension, setting the stage for coronary artery disease, and if it's unmanaged or untreated, ending with something like heart failure. Okay, so just a little bit of housekeeping. Here's all of the enzymes and proteins that are responsible for maintaining cholesterol homeostasis, all listed here. And the different drug indications and so forth will refer to some of these, and so you can just kind of refer back to this for a studying sake. Okay, so physiology. what do lipids do? Well, we know that chemically they're insoluble in water, right? So the blood is more of an aqueous type of environment. So these lipids have to bind to something, okay? They have to bind to carrier molecules called proteins, and that's what propels them through the blood plasma. Typically, when we talk about lipids in the biochemical sense, we're referring to cholesterol, triacylglycerols, and phospholipids. All right? Lipids are transported through the plasma, and these large molecule complexes are called lipoproteins, and this is kind of the basis of hyperlipidemia, because these patients have excess lipoproteins within the vasculature, and that kind of precipitates a lot of their pathological problems. Remember, there's both an exogenous as well as an endogenous pathway, which are described there, and then again in more detail in the course notes. Okay? This is a nice overly simplified diagram of how lipids are accumulated within the body. Essentially, we're looking at dietary fat and cholesterol intake, right? So it's the food that we eat that contains high amounts of lipids, that contribute, that contain high amounts of cholesterol that contributes to their accumulation within our lipid profile. All right? And there's the legend for that figure. This is coming out of Goodman and Gilman, which is, again, the Pharmacology Bible. You can read that when you review. And again, just for review's sake, this is the origin of where some of these lipoproteins are coming from, right? So HDL, remember, is coming from the liver and from the intestine, and that's the removal of excess cholesterol, right, from tissues and the remodeling of lipoproteins. And so HDL is known as the what cholesterol? Good, right? HDL is good. This is in opposition to the LDL, which is found primarily in the plasma and transports cholesterol from the liver to the periphery. LDL is the bad cholesterol. See, you pretty much know everything. We're done. Okay? Here's a bunch of enzymes that are responsible for different metabolic roles of cholesterol homeostasis and lipid accumulation homeostasis, all depicted there. And of course, you know, there's a genetic component to this, which we'll discuss in the next upcoming slides. When we talk about hyperlipidemia, we're really referring to the Western diet of steak, potatoes, Taco Bell, Dairy Queen, ice cream. I'm thinking of all the things I had the last 3 days. And, you know, that Western diet that contributes to our detrimental health, right? So there are genetic causes of hyperlipidemia called dyslipidemias, and many of them result from some type of mutation in many of these enzymes that are depicted here. And we'll discuss this again in detail later. But just, you know, FYI, there's the thing that we all associate with atherosclerotic plaque form up, and it's our crappy Western diet, but there's also a genetic basis as well. Remember, in terms of nomenclature, that these lipoproteins are classified according to their density. So LDL, HDL, VLDL stands for high density, low density, and very low density lipoproteins. Okay, and so remember, the greater amount of protein that exists within that molecule, the greater the density. And that's what these molecules look like. They're quite large, right? So go back to our physics or biophysics of blood elements within the vasculature, right? So I like to think of it in terms of these large, bulky molecules that are traveling through the bloodstream. Based on their size and their density and the speed at which they could possibly move through a closed blood vessel, where do they most likely partition to? Just like the semis on the Dan Ryan, they usually, hopefully, partition to the periphery, right? To the sides of the vessel of the lumen. Okay? And so when there are large numbers of these lipoproteins, why is that problematic? Well, these large bulky molecules start bombarding the endothelium. They physically hit it, and that causes the endothelium to become activated, and that sets a whole series of physiologic changes within the vasculature that sets the stage for the beginnings of atherosclerosis and some of those lesions that you're going to learn about or have learned about just recently. All right? And again, these apolipoproteins are essentially the building blocks of lipoproteins, okay? And so certain apolipoproteins are associated with certain high density or low density lipoprotein molecules, and those are depicted there. And so the site of all of this process is occurring within the hepatic cells, correct? Right? And that's important because many of these drugs actually are designed to have their main mechanism of action within the hepatocyte. and that's extremely helpful. And so here's kind of the biology of where these, how all these different blood or lipoprotein elements interplay with one another. I'd like to start here at the LDL receptor, right? So that's one main thing to kind of keep in mind. When we talk about LDL, HDL, and so forth, we're talking about serum-associated lipoproteins, right? So in terms of our pharmacology language, we're talking about the ligand, right? The floating thing out there in the periphery that floats around within the blood vessels, binds to some of these cholesterol molecules, and brings them from point A to point B. And so they signal, they operate, this is the ligand, they operate through the receptor, and the receptor can be found in a variety of tissues, but most likely the LDL receptor we're talking about is found on the hepatocytes. Okay, so the LDL receptor, and then the LDL ligand, or the molecule that floats around within the blood plasma. You guys already knew this. HDL is the good guy, LDL is the bad guy. HDL is found on the intestine, associated with liver and plasma. And here it's functioning to remove cholesterol, right, from the circulation and then bring it back to the liver, right? So one therapeutic goal or advantage would be to find ways in which we can increase HDL. So cholesterol gets removed from the system, right, removed from the vessels, and sent back to the liver for recycling. This is in opposition to the LDL cholesterol, lipoprotein molecule, which is the quote-unquote bad cholesterol. That's one that's associated with the formation of these plaque deposits within the vessels. And our therapeutic goal is to reduce the amount of LDL. And so we've, of course, got drugs that can do both. We'll talk about those in a minute. So the rationale for reducing them is because, we can contribute to the process of the pathogenesis of atherosclerosis. We can also cause acute pancreatitis when these molecules are in excess, specifically when we're talking about excess LDL. And there's a genetic component as well. There's alterations in lipoprotein structure. There's alterations in the enzymes that can metabolize some of these reactions. And then, of course, going back to our Western diet is, showing to be the major underlying cause for most people. These are those disorders that I've talked about. They're all listed here. Okay, I just want you to be familiar with them, because there are patients that may have a really good diet. They might be runners. They might be marathon runners. They might have 5% body fat, and they could still have crappy cholesterol numbers. Okay, this genetic cause may explain some of that. All right. What's the outcome for many of these? Well, look at this. Okay, decreased LDL receptor expression, increased LDL, low HDL, increased LDL. High levels of LDL. Okay, so it doesn't matter what they eat, right? If they've got a good diet or a bad diet, they're gonna have, many of these are gonna have high LDL levels and low HDL levels, right? And that's a problem. So we're gonna treat them just like some of our other patients, maybe a little bit more aggressively, okay? With the understanding that probably diet and exercise isn't really going to contribute that much to some of the preventative medicine strategies that a normal patient would experience. Okay, so those were all primary hyperlipidemias. There are some secondary hyperlipidemias, okay? Some that are associated with too much cholesterol, which are depicted here on the left, and some that are associated with too much triglycerides, which are depicted here on the right. And so you can see many of these could be drug-induced. And so a consequence of some of these drug therapies could be triglycerides in excess. And we kind of saw this back in the day when we looked at hormone replacement therapy in postmenopausal women and the higher incidence of strokes after so many years of being on those hormone replacement patches, pills, and so forth. Okay? And so you'll learn about this in the pathophys component, but remember, dietary fat contributes to cholesterol, obviously, within the diet. That's where it's coming from. And it's going to transition from liver to blood to peripheral tissues, and that's going to have dramatic consequences in terms of how these lipoproteins function and basically the patentability or the openness of some of these blood vessels. Okay? Now, what's interesting here is that there's one receptor that you see in all of these diagrams, ABCA1, where's the other one? ABCA1, and there's another one over here somewhere. That's an ATP binding cassette efflux pump, very similar to the multiple drug resistant pump or the P-glycoprotein pump that we talked about. But in this case, it's not pumping xenobiotics or foreign molecules or chemotherapy. It has a high affinity to cholesterol, okay, and only cholesterol. And so that's how really cholesterol goes from each of these compartments quite easily, is that this receptor is found in all of these three anatomic compartments. Now, from the immune perspective, it's really important because this particular macrophage, once it hits, so once it comes in contact with oxidized LDL, okay, that macrophage changes its phenotype, it changes its characteristics, and it becomes a foam cell. Foam cells are one of the contributing factors to the driving force behind atherosclerotic lesions and plaque formation, okay? So those sticky macrophages are extremely problematic in the hypertensive individual, as you'll soon find out, you know, as well as patients that just have high lipids within their blood. So what about cholesterol? Remember, it's a naturally occurring sterol, right? You need it. You can't avoid cholesterol. Your body's going to make it no matter what you do. It's a precursor to bile salts. It's also a key component to the plasma membrane. And it's also the building block of all steroid hormones, right? So your body, doesn't matter if you're a boy or girl, your body is going to need cholesterol to make either testosterone or estrogen. Okay? Triglycerides are important too. It's the main component, the main storage component within the adipose tissue, although everybody wishes they had less adipose tissue. We all need some adipose tissue, right? And those are basically synthesized from fatty acids and glycerol. All right? So let's just kind of briefly go over some of the lipoproteins within the plasma. The largest of these lipoproteins is the chylomicrons. Okay, and these are very, very large protein molecules. They enter the circulation from the thoracic duct. All right? And after a fatty meal, these things float around in excess for about 12 to 14 hours, so which is traditionally why we've told patients, you know, before you're going to go for a lipid panel test, you should fast overnight. So no food from about, 9 o'clock, 10 o'clock at night until the following morning. And the reason is we would like to rid the sample of all of these chylomicrons, which could skew results. That's kind of been the traditional approach. I just went for my lipid panel 2 weeks ago, and they told me I didn't need to fast. I said, well, why not? Well, we've got a new fancy schmancy machine that sucks the whatever out. I said, well, instead of using it on my sample, hook me up to it. But you know, that didn't go over well. Okay. You know, so these chylomicrons are involved with the transport of fatty acids and cholesterol. Okay. Very low density lipoproteins play a key role in pathogenesis of atherosclerosis. You'll see this in the pathophys components of this course. And of course, we've talked about the importance of low density lipoproteins as well as high density lipoproteins, the good cholesterol. Okay. And so this is kind of a general consensus of where we'd like to see some of these lipids in patients. This I stole from the textbook back in 2001. The guidelines have changed slightly, so this is just kind of a nice reference. I copied a whole bunch of current guidelines published this year towards the end of this lecture. I'll post that paper in the reference materials for this class. But I thought maybe when we do the last 10 minutes discussion, I can kind of post the guidelines.
Yeah. I'll guide them towards where they can
Perfect.
find it.
Yeah. You know, so the textbook one, this is textbook definition. No, there's a little bit more material beyond this, but you know, in generalities, this is sufficient. Okay, and just more review. All right. So the patient comes in, the blood test, my results come back, and it's, you know, my doctor sees it. He says, well, you know, Mike's got high cholesterol. What do we do? Well, first we counsel the patient, diet and exercise, right? So you'll see me at the gym probably in the next couple of days because I feel bad about my lipid profile, right? We got to control diabetes if applicable because you'll see the interplay between diabetic patients and then hyperlipidemia as well in the next coming weeks. Okay, so obviously diet plays a huge part. We've talked about smoking cessation. All that may not work, right? And so what do we do? Well, pharmacotherapy. So these are the 6 drug classes that we use for managing patients that have too much cholesterol in their blood. Okay? And you've all heard of the first class, statins. It's like the wonder drug of the 21st century. How do they work? They competitively inhibit HMG-CoA reductase. I'll show you that mechanism in a minute. Second class is niacin. These are vitamin B derivatives. Third class is fibric acid derivatives. Fourth is bile acid binding resins, inhibitors of intestinal sterol absorption. And the newest class, number 6, the PCSK9 inhibitors, which is a monoclonal antibody. So all the rest are chemicals, and the 6th class is a monoclonal antibody blocking a key receptor. Let's get into how these work. So this diagram is a generic one from Katzung that shows basically 4 of the 6 mechanisms and how they relate to the hepatocyte. Okay? So here's how cholesterol gets synthesized. Acetyl-CoA gets converted via HMG-CoA reductase into cholesterol. This is not a one-step biochemical process. It's about a 12 or 13-step process, but we've just shortened it here. Statins, all of them, inhibit HMG-CoA reductase, which is the first step and also the rate-limiting step of that reaction. Okay? Niacin really inhibits the cholesterol incorporation of the incorporation of cholesterol into some of these carrier molecules, whereas ezetimibe, which is the brand name Zetia, inhibits the absorption, as well as resins inhibit the absorption of cholesterol from the gut, okay, into the hepatocyte. Okay? So the sites of action for these drugs are listed here, 1 through 4, shown there. In many instances, when we inhibit cholesterol production, the outcome, or the side effect, is going to be an increased expression of the LDL receptor. Why? Because we've removed a good chunk of the ligand that was available to bind to that receptor. So that's a classic pharmacodynamic interaction. If you reduce the concentration of the ligand sufficiently, you upregulate the expression of the receptor. Okay? Statins and resins are notoriously known for upregulating the LDL receptor. Right? Let's go back to some history about statins. First isolated from fungal metabolites back in the 70s from the genus Penicillium. All right? So Merck isolated lovastatin in 78 from Aspergillus. And that basically laid the foundation for what's known as the lipid hypothesis of cardiovascular disease, which I put on this slide because I didn't want to screw up the numbering. The lipid hypothesis states that basically what I described earlier, the lipids, high-density lipid or low-density lipids that will bombard the bloodstream will actually cause the endothelium to become activated, will assist in immune cell recruitment, talking about macrophages, foam cells, okay? And alter and increase platelet aggregation and adherence. And so that lipid hypothesis was actually quite controversial when it was first laid out. Now we've been taking it as gospel. Statins are great. They're relatively safe. Okay, they're well tolerated. They got really minimal side effects. And essentially, they're a wonder drug. They're also a blockbuster drug. They've made billions on that drug class. Okay. Off the record, they might be efficacious in other diseases. I'll show you the biochemical pathway later, and we'll kind of relate that to possibly the use of statins in other diseases. Oh, here's the biochemical pathway right here. I thought it was one slide later. So here's the building blocks of cholesterol, acetyl-CoA, okay, where we make HMG-CoA, gets converted to mevulanic acid. This step relies on the activity of one enzyme, HMG-CoA reductase. So statins competitively bind and inhibit that enzyme. And so essentially this pathway stops at the production of mevulanic acid. So the outcome here is that we're going to reduce or severely inhibit cholesterol synthesis. All right? But there's also going to be a reduction in this pathway too, in terms of prenylation and ubiquitination, okay, which relies on this cholesterol biosynthetic pathway during geranyl-geranyl phosphorylation, which is shown here. You know, so some of the untold side effects or some of the other effects of statins coming from inhibition of one or both of those two pathways. Okay? I used to do research on statins before I came here. I used to make my students read a 35-page review article on statin pharmacology, right? So we're only telling you the first 2 paragraphs of that review paper. There are 34 and a half other pages that talk about what statins can do in terms of chemokines, in terms of platelets, in terms of immune cells, macrophages, and so forth. All right? We know that when we give a statin, we're going to reduce cholesterol. We're also going to reduce prenylation because this process is inhibited. What's prenylation? Do you guys remember from biochemistry? Prenylation is really a post-translational modification where you add a lipid moiety to a compound. And so if it's a macromolecule, or even just a regular size molecule, if it's a protein and you prenylate it, it's going to change the solubility of the protein. So typically when you see prenylated proteins, they move from the cytoplasm to the plasma membrane, or from the cytoplasm to the nuclear membrane. So you're basically making it more hydrophobic. What do we see clinically? Well, when you give a statin, you're going to reduce serum LDL, okay, because there's not going to be much cholesterol available to be incorporated into the LDL molecules, and so the outcome is going to be a reduction in serum LDL. And we're also going to see an increased expression of the LDL receptor on the hepatocyte. These are all the statins. Obviously, it's easy. They all end in statin. Lovastatin, bless you. Lovastatin was the oldest in the group. And I want to say rosuvastatin is the most recent, right? Crestor. It's also the most potent. I think in the course notes I sent a diagram that looked at the relative potencies of all the statins compared to each other. And that was kind of a general rule of thumb. And so the take-home message with that table was that, if you wanted to lower LDL by 20%, you don't need to give the really potent Crestor. You can get away with maybe 10 milligrams of lovastatin. If you wanted to lower LDL by 70%, perhaps the Crestor would be a good pick because you can get a reduction of LDL by 60 to 80% with the maximum amount of Crestor, 40 milligrams. Okay. Pharmacodynamically, older members of this drug class are administered as a prodrug. Those two, well, there's actually 3, but the 2 that are listed here, lovastatin and simvastatin, are prodrugs. So remind me, what is a prodrug? Exactly. So it's not biologically active, okay, and needs hepatic metabolism to become modified, to become biologically active. Okay, perfect. Chemically, hydrolysis occurs in the GI tract, okay, but most of the biological activity is coming at the site of the liver. And this is great, right, because that's the site where our target is, right? That's the site where HMG-CoA is active, for the most part. That's where HMG is expressed. And so you want to have the maximal effect at the site that it becomes administered. Okay? So there's a high first-pass extraction rate coming from the liver, and this is excreted basically by bile, and some metabolites go into the urine. These half-lives range from anywhere from 4 hours with, I forget which the shortest one. Atorvastatin's 14 hours. Atorvastatin is Lipitor. You've all heard of Lipitor. And rosuvastatin has the longest half-life of 19 hours. Typically, we tell patients, take this at night. Why do we have them take it at night? That's when cholesterol synthesis occurs, right? So just before bed, take your one of your statins. You should see a dramatic reduction in LDL very quickly, once therapy is initiated. So in terms of the physiologic effects, we're going to see an increased number of the high-affinity LDL receptors. That's on the hepatocyte. We're going to increase LDL catabolism, and that's going to reduce serum LDL levels by anywhere from 20 up to 60 or 70%, depending on the patient. Okay? However, we'll see a modest reduction in triglycerides, anywhere from 10 to 30%. So the patient's triglycerides are extremely high, and you'd like to see a 60th percentile reduction. A statin probably wouldn't be your first choice. with a statin in general, we can see small gains in HDL, and that varies by the statin. Okay? Some reports say that Crestor can increase HDL levels by as much as 25 or 30%. Okay, so the 15% is kind of an average. And as I said before, we'll see reduction in prenylated proteins. This has immune-type consequences, which are listed there. And you'll probably see more research in the next coming decade in terms of the statin effect on prenylation. That's kind of a new emerging field. So how do we use them? Well, we can use them alone. Actually, by themselves, they're quite efficient at lowering cholesterol and managing patients that have, atherosclerotic, evidence of atherosclerotic lesions as well as hypertension. You can also combine them with some of the other drugs within this presentation we'll talk about. And as of right now, statins are essentially the most powerful cholesterol-reducing agent on the market. We don't like to give them to women who are pregnant, who are lactating, or who might become pregnant. And we have given them to children in severe cases, specifically the genetically inherited versions of some of these hyperlipidemias and dyslipidemias that are depicted there. So all in all, statins, great group of drugs. They do have some toxicities, of course. We see elevated serum aminotransferase activity. We'll see increases in creatinine kinase activity. Probably the one thing that most people that are on a statin complain about is this muscle weakness, specifically in the legs. And it's described as a soreness or a persistent muscle ache, similar to the way you feel after running, 2 or 3 miles or not hydrating before a workout, and that feeling of the lactic acid within the muscles. It's not lactic acid. It's actually rhabdomyolysis coming from myoglobinuria. And if it's left unchecked, it can actually contribute to some type of renal failure. Okay, so it's an important side effect and toxicity to be aware of, but when you compare it to all the other drugs that we've talked about so far, it's not that bad, right? Remember some of your chemotherapeutic drugs, right? So there are some pharmacodynamic interactions. It's catabolized or metabolized by the P450 liver enzyme system. So lovastatin, simvastatin, and atorvastatin are all CYP3A4 substrates. Right? So if you combine that, remember again with pharmacodynamics, if you combine these drugs with a CYP3A4 inhibitor, such as cyclosporine, ketoconazole, grapefruit juice in high doses, you can actually have high accumulations of these drugs within the serum plasma. Okay? And there's also a pharmacodynamic interaction with another group of drugs, fibrates, which we'll talk about in a few minutes. There's a renal clearance pharmacodynamic interaction that revolves around glucuronidation.